All right, everybody, welcome back. Today on the episode, I have Dr. Walter Sussman. He is the owner and founder of Boston Sports Biologics. He is a doctor of osteopathy. His background involves diagnostic and interventional musculoskeletal ultrasound, peripheral joint injections, nerve hydrodissection, soft tissue injections, orthobiologics and regenerative medicine, which means kind of PRP, stem cell injection type stuff that you might be familiar with. He also does a lot with sport-related concussion management, and he also has a lot of training with osteopathic manipulative medicine and pre-participation sports evaluations. This guy also has 21 publications and 14 chapters contributed into textbooks. So he is quite a man with accolades, and we're excited to have you on because there's a lot of things that are coming out now that we see. Times are changing with medicine and what we can do and what's good, what's bad. So I'm really excited to talk about this. So after that intro, is there anything else you want to discuss about your background and training and what you do?
No, it's, I appreciate you having me. My training after medical school was in physiatry. So a lot of chronic musculoskeletal and orthopedic issues, and then sports medicine. So some of the acute issues. And so, we really try to take care of, the head to toe musculoskeletal issues and offer, some of these newer treatments that have a faster recovery and get people back to sport quicker. So.
Yeah. And so I think one of the biggest things too is, what is the difference of coming to a practice like yours and then going to a traditional orthopedic surgeon or sports medicine doctor?
It's so much of medicine's gotten carved up into smaller and smaller pieces, right? So you go to your orthopedic surgeon and they may not take care of elbows. They may only take care of a shoulder and then you need a separate opinion for your elbow. And so, the benefit of coming to us is that, we can look at the body comprehensively, and try to give you some direction and kind of more of a global plan. And we work very closely with a lot of the surgeons in our community because there's some stuff that you can't fix with these non-invasive interventions, but around 85% of musculoskeletal issues are non-surgical. So it makes a lot of sense to start either with a physical therapist or with us or somebody who kind of views it from a non-surgical standpoint before jumping straight to surgery. Now there's certain things, acute tendon ruptures that need surgery and they need it within a short period of time of the injury. But most of these chronic injuries, you may be better off starting with the non-invasive conservative measures. And we do a little bit about all of them, so you're not just seeing somebody who does Shockwave or just seeing somebody who does cortisone injections. We can kind of offer the spectrum.
Mm-hmm. And so what are some of the procedures you guys do that are different from like a traditional orthopedic? I know there's a lot on your website. Do you want to just kind of go through some of those real quick and then we'll dive
Yeah, the biggest workhorse in our clinic is ultrasound. It allows us to, x-rays are great at showing bone, but most of these injuries are soft tissue injuries. And so, just like an MRI, you can see a lot of soft tissue injuries, ligament or tendon injuries. A lot of times we can do the ultrasound same day, so we can give you an answer pretty quick. And the biggest thing we do, is coming up with a good diagnosis. Once you have a good diagnosis, you can figure out what structure is causing pain. You can address that and the compensatory issues. So, we're not going to start necessarily with physical therapy and see you back in 6 weeks. We're going to try to get to the root cause before we send you off to a therapist or before we offer you a procedure. And then really trying to tailor the procedure not only to what's going on with you, but also where you are in your activity cycle. Are you in the middle of, tennis league? You can't do anything for 6 weeks or 3 months. Our treatment's going to be very different than, if it's your off season. And so, come up with a good diagnosis and coming up with a treatment plan is kind of where we start with a lot of these, and then tailoring the treatment plan to your goals.
And something I have as a physical therapist that I see people getting a lot of, and I don't know if you do them. What are your thoughts on cortisone injections?
They have a role. They're great at managing pain. A lot of time it's not inflammatory pain though. but they can calm down neuropeptides and really turn off an inflammatory cycle. So, if somebody comes in with a really swollen knee, getting the fluid off the knee and putting a cortisone injection may not be the worst decision. If somebody has to go to a wedding or a trip, and needs a quick fix, cortisone oftentimes will provide that. Or, it can give you a window where you can calm down the pain so you can try the therapy or you can try some of these other modalities. It seems to be the dose relationship with cortisone in the tissue that really becomes problematic, because if you put cortisone in a petri dish with cartilage cells or tendon cells, it's toxic to the cells. And the higher the dose, the more toxic it is, based on some of these animal studies that we see. And so it's not something you want to get 15 shots of cortisone and really degrade the tendon, or, 4 cortisone injections a year into your knee, where that may speed up the arthritic progression. But a once off here or there, probably still has a role. There are other options. Toradol is a liquid ibuprofen type medicine that also has similar effects head to head with cortisone in a lot of studies. So that's another option, especially if you're a diabetic, or you have osteoporosis, or there's another contraindication to cortisone. So there's other options out there that would provide similar anti-inflammatory effects.
Yeah, because that's the thing I've seen is long-term use of them. Like, we've seen a lot of people, it's like, oh, I got these cortisone injections and now actually my knee's worse than it ever has been before. And it's like, okay, is that from overuse of the cortisone? And depending on that, not fixing the root cause or regenerating tissue or whatever other things we can do these days.
Yeah.
So
we'll have some patients who've had 17 cortisone injections for hip bursitis. We've known for 20 years that that's really not a thing. Now we get MRIs, you don't see bursitis. It's not an inflammatory condition. So first off, it doesn't really make a ton of sense to be doing that, but you'll see the tendons melt. You'll destroy the architecture of these fibers. And then some of these other things, may not work, and surgery may not even work in some of these situations. So being cognizant of, how many cortisone injections you have is important, I think.
Yeah. Is there a point where it becomes like negligent, or like a certain amount of injections you would get in a single joint before you're like, all right, we need to do something else?
Yeah. I think anything, if you're not making progress, and it's 2-3 months, whether that's an exercise program or, these injections, or PRP injection or 2, stem cell, if those aren't working, you got to figure out something else. Mm-hmm. And so, continuing to do the same treatment plan when it's not really working doesn't, I think you got to pivot in those situations. They just call that insanity when you keep repeating the same thing. And then what types of conditions do you guys typically treat in your office? What do you see in the most common? Yeah, we'll treat everything from, musculoskeletal, muscular injuries, strains, more acute injuries, chronic musculoskeletal pain, chronic tendon pain, arthritis. We'll see a couple of broken bones here or there, concussions. So, really, we see a little bit of everything. If it needs surgery, we'll coordinate with the surgeon too. But, I think the things that really distinguish, I think the stuff that's out there now that's new and novel and offer better outcomes are the options for these chronic tendon injuries, where the tendon is just frayed. You can almost think about this as a rope that's started to degenerate and fray and puff out, and those fibers just aren't working the way they're supposed to. So I think a lot of those newer treatments offer faster recovery and better outcomes. There are some less invasive tendon procedures that are these mini surgical procedures. We're doing some mini surgical procedures for carpal tunnel and trigger fingers, where people are back to work that day or within 3 days on average. So again, much faster recovery than the traditional orthopedic approach. Mm-hmm. So I think those are the things that really, you're not going to get at your traditional orthopedic clinic. Yeah.
So that's what it seems like to me. And that's what I'm kind of curious about too, is when should someone consider going to you or someone like you over going to the traditional orthopedic surgeon?
Yeah. I think that chronic tendon injuries, a lot of these things get missed too, because they don't show up very well in an MRI. And so these are the other thing that, if somebody is really struggling to find a diagnosis, or, you're kind of in this treatment gap between anti-inflammatories and physical therapy, and all you're being offered is a surgery, and it's not a full tear. It's more just an inflamed tendon or a thickened tendon. Those situations, a lot of these treatments are going to offer you a faster recovery and comparable outcomes to the surgical options.
Yeah. So would it be right to say you guys tend to see like things you're going to see aren't really on the acute traumatic side, but more of like chronic overuse? Someone's pain has kind of set in slowly over time and gotten worse to the point where like they're just kind of stuck and can't figure out where to go.
Yeah. Yeah. And, you're told you're not a surgical candidate, you may not understand why, or, your therapist is, feels like you kind of plateaued, and these are these gaps that, you feel like you don't have an option. These can really give you some hope.
Cool. And so some of the big things you guys do that I want to talk about that a lot of people ask us about all the time, two big ones being, should I get PRP and should I get stem cells? So I want to talk a lot about those. So PRP, what is it, and what is it typically used for to start?
Yeah, it's so PRP's been used in medicine since the 70s, and it's really just a concentration of platelets within your blood. And so you have three different types of cells in your blood. You have red blood cells, which carry oxygen. You have white blood cells that fight infection. You have platelets that are kind of responsible for the healing cascade or healing process. And so we use different lab equipment to concentrate the platelets out of your blood and discard the parts of your blood that you don't need. Within platelets, there are a lot of proteins and growth factors, and that's what we're using the platelets to initiate a healing response, at least for soft tissue injuries. For arthritis or broken bones, it seems to heal up, maybe speed up a fracture, but for arthritis, it turns off inflammation. So depending on what we're treating, it works differently, and how we process it is slightly different. At the basic level, the FDA defines PRP as any platelet blood product where the platelets are higher than baseline. But we've really learned that there's a dose-response relationship with PRP, just like with any medicine that you take, right? Maybe you take one Advil, it's not enough. Maybe you need two for the headache, or three. So your body may respond at a higher dose where a lower dose doesn't, and that seems to be the case with PRP as well. And so it's an in-office procedure. We find the location of your pain with ultrasound, with maybe some diagnostic numbing injections, really find out where your pain's coming from. And then once you're numb, we'll put the PRP either into the joint or the tendon to initiate that healing response or to turn off inflammation for a period of time.
And so you guys use, I was under the impression that PRP was more for tendinopathies and like chronic tendinous or muscular issues, where you guys are also using it for arthritis as well.
Yeah. So it works differently though. So, when we talk about PRP, or we talk about these different types of stem cell products as a regenerative or reparatory product or injection procedure, in tendons or ligaments, that seems to be the case. There are studies out there that show that on serial X-rays or serial ultrasound or serial MRIs, you can see those tendons repair, those gaps and interstitial holes within the tendon disappear. Arthritis, it doesn't regenerate cartilage. It does in a petri dish, but for arthritis, it seems to work differently. It seems to turn off inflammation within the joint, and at a high enough dose, it may actually slow down the progression of arthritis. There's a Bansal study and a Chen study that have come out. There's a big systematic review looking at dosing. And at a high enough dose, it may slow down the progression of arthritis, at least for knee OA. And we kind of translate that to other joints where there may not be studies to support that claim.
And how long, if you do a PRP injection on someone for, say, knee osteoarthritis, how long will they experience that reduction in pain and inflammation, typically?
Well, hopefully about a year or two.
Okay.
And then you can repeat it. So as long as this is something that's providing you pain relief, allowing you to do more, improve your function, this is something we can do indefinitely. Just like with the gel shots, people will manage their arthritic pain with those as well.
And the thing with this too is there's no real negative side effects to doing the PRP, where you're putting your own blood back into you, just in a higher concentration, correct?
Yeah, the most common side effect is inflammation related to the procedure. And so you will, because these are The healing process is initiated by this kind of inflammatory cascade. And so if you have a cut, you get red and inflamed around that area. That's the first initial process of healing. So those first couple of days, you're going to get swelling and pain and discomfort, but that's normal. You see that sometimes with other injections too.
Mm-hmm.
The biggest risk is probably financial because these things aren't covered by insurance yet. And so, if you pay out of pocket for a procedure or an injection, it doesn't work, that's probably the biggest risk with this,
mm-hmm.
As well as any, comparable risks of infection to any other injection around the knee.
And why won't insurance companies yet cover something like this?
So it's a good question. And
no money in it?
Well, there is a cynical side of me. Nobody's making a lot of money off using your own blood to treat you. Whereas
mm-hmm.
if you're a big pharmaceutical company who's selling you a gel shot for $1,000, somebody does have, an incentive to,
mm-hmm.
These drive down surgical volume. There are areas of the body where there's less data to support this. But for knee arthritis, there's 122 randomized control studies showing that this, and most of them outperform at the right dose, viscosupplementation, cortisone injections, the standard of care.
Mm-hmm.
And so this gets labeled as experimental or not FDA approved. And there's a lot of nuance in that,
mm-hmm.
It has been studied. So, and there are studies showing positive results. So we still pay for surgeries where there's, so I quote the patellar tendon data because there's 2 randomized control studies showing that surgery for chronic patellar tendon pain does not outperform physical therapy.
Yeah.
Yet we cover that as a beneficial surgery. There were 2 randomized control studies last time I looked for PRP for patellar tendonitis, and it did well. It outperformed therapy. And so there's more data to support PRP for patellar tendonitis, but we still don't cover it, but we still cover the surgery. So, some of these things are hard to grapple with why it's covered or why it isn't.
Yeah.
The nuance, we always get asked about FDA, this isn't FDA approved, but the FDA does have a stance on this. And the FDA doesn't approve every blood transfusion you get, and they put this in the same category as a procedure using your own blood. So as long as it's not significantly manipulated and they don't view you as making a new product out of that patient's blood, making a drug, they don't regulate it. They don't regulate hair transplants or heart transplants or blood transfusions. So it falls in that bundle of a medical procedure that they're never going to regulate.
It's not a supplement even, and it's not a medication.
Right. And so they don't view it as a drug, and they're responsible for regulating drugs and medical devices.
Mm-hmm.
Now, all the devices that we use in our clinic to make PRP have all gone through the FDA regulatory process.
Mm-hmm.
So in that sense, it's FDA approved.
Yep.
Machinery and lab equipment that we're using, it's just they're never going to approve this as a procedure, yet that's what the insurance companies use to justify them denying it.
Yeah. And I've heard a lot of different things through the grapevine from some surgeons or sports med docs. So I was actually at a Shockwave conference, and I was talking to a sports med doc that does PRP and Shockwave. And what is your thought on lifting after PRP, or is there some type of, there's probably not even a studied protocol on it, but he was saying not to lift heavy. Like he did his rotator cuff, he did his super spinous, I think. I was like, so what does, aftercare look like and like your plan of care? He's like, well, you can't lift heavy. I was like, well, what does heavy mean to you? Like, it's a very relative term. And then he was saying it could leak out of the joint. And I was like, okay. So do you have anything to say on that or any stance on that?
Yeah. So, let's divide into like tendon, like a rotator cuff or a joint, because it's slightly different. There is a study looking at them putting PRP into an Achilles tendon.
Okay.
I think it was a cadaver model. And then they moved or it may have been a human model, but they moved the patient's ankle back and forth. And the PRP didn't leak out. So they had this protocol where they moved the ankle back and forth like 50 times right after the injection and stayed there. And so, our tendons are surrounded by this fibrous material. This is the, if you ever cook ribs, the silver skin or meat, that surrounds muscles. And so if you get it in the tendon sheath, and it's surrounded by that fibrous tissue, it's going to keep it in there. In addition, most of the granules within these platelets get activated within 10 minutes of the procedure.
Mm-hmm.
And so once that cascade starts, the PRP, one, it's not going to leak out, and two, that inflammatory process has already started within an hour of your procedure.
Mm-hmm.
Now, the reason not, to do a graduated rehab program is because of the healing cascade that we've just started.
Yeah.
And so the first 2 weeks, it's this inflammatory stage. And
Mm-hmm.
so there's no value in lifting. In fact, it may be weaker and you may be compromising, lifting on compromised tissue.
Mm-hmm.
Around 2 weeks, you'll start laying down tissue. And as that tendon gets stronger, you can start to do more. But the first wave of healing is mostly type 3 collagen fibers, which are thin and stretchy and vulnerable. So if you lift too hard, you're going to disrupt this matrix, the scaffolding that your body's starting to produce to fill in that defect in the tendon.
Yeah.
But by 10 weeks in, you're starting to get into this maturation phase where you can do more. And it's going to be really hard to mess things up. And so we allow you to kind of do more over time, but that's the reason you kind of modify things.
Yeah, that makes sense with you're creating a negative, or it starts as like a negative healing cascade that turns positive, but and
it's
I
like
know
picking a scab too early on, you just don't want to do too much early on and disrupt that healing process.
And that being said too, like I think he said like don't lift heavy for 6 weeks, and I was like, this doesn't make sense. Yeah. And I had a patient that was told like don't do anything with your arm, and he came in, I think he did Prolotherapy, but he ended up with a frozen shoulder because he had so much like told fear avoidance of doing anything. He literally didn't move his arm. He was like, he might as well have been in a sling for 6 weeks. And then his rotator cuff tendinopathy was even worse with a frozen shoulder on top of it. And I was like, okay.
Yeah. There's a window where you have to load these. And so, frozen shoulders, it's for shoulder surgery. Between 5 and 30% of patients, depending on the study, will develop a frozen shoulder after a shoulder procedure. Mm-hmm. And so, we see them after PRP, even if the patient does everything right. Sometimes this is just inevitable. But the first 24 hours, really maintaining range of motion is important. Now, the other thing that you see if you don't load the tendon is you see tendon hypertrophy. The body will just lay down tissue, but it won't remodel. And so we see tendons get really, really thick if they're not loaded early in the process. And so 2 weeks in, we'll get out of a boot and we'll start loading that tendon to avoid that situation. And so there's animal studies that support this. Not great human studies yet, but based on animal studies, there's a window. And if you don't load the tendon, you'll form scar tissue within that tendon based on that animal model. Mm-hmm. And that's exactly the opposite of what we want to do with PRP. Yeah.
And so what would your loading protocol look like, or like what types of loading would you be doing in general with a tendon, after that 2 week mark?
So usually the first week's isometric, you just load it, but you're not lengthening it. Then start some concentric exercises for another week or two, and then evolve into heavy, slow resistance training or eccentric training where you're starting to push things that second month. So once you're getting to like week 4 or 5.
So it's kind of different from like the regular tendinopathy model, where instead of going isometrics to eccentrics, we're going isometrics, concentrics to eccentrics.
Yeah. And not just kind of buying time, but allowing you to load the tendon a little bit heavier than you would with an isometric protocol. Mm-hmm. But a lot of it's focused on more conditioning, low weight bands, high rep, that first. And so I usually tell people, find a resistance where you can do 15 reps, 3 sets of 15 comfortably, keep that resistance, and then just do more of them over the first 2 months. Okay,
cool. And then have you ever experienced anyone pairing these with blood flow restriction training at all too?
Yeah, it works great.
Yeah.
Do that.
Yeah, we do a lot of that. I've done a lot of it with some PRP patients as well, and we've had good success, but I don't know if there was any data to support that too or not, but
there's not, but
it seems like they would.
It makes sense. A lot of times you'll deactivate those structures. And so, getting better blood flow, activating and conditioning that area. Yeah. That I think that only helps.
What about, so this, in this thing of like thinking about pressures and things maybe leaking out, like say it was a shoulder you did, would you do PRP within those first 2 weeks, even just having them like at rest, just to get the benefits of like, we know with BFR, there's plenty of benefits just even putting them on for 10 to 15 minutes and doing nothing.
I haven't thought about it, but it's not a terrible idea, right? Just helping support blood flow there. There are people who are dogmatic about not using ice, and only using heat after PRP. I mean, these structures are deep. I don't think that makes a huge difference one way or another. But again, the whole idea is, how do we promote blood flow there? One of the hormones or one of the growth factors that gets excreted is vascular endothelial growth factor. And so you'll see the body build new blood vessels into these areas as highways to bring in new cells, new stem cells, support cells as part of the reparatory process. And so BFR, similarly, increases blood flow to an area and may only augment that process.
Cool. And then anything else on PRP you wanted to talk about there?
Yeah. So, as far as the joint, so that's kind of our approach with the tendon. Once it goes in the joint, there's a joint capsule that holds that in place. Yep. And likewise, you're going to see most of these growth factors released in the first hour, and the rest of them probably within the first 24 hours or so. And so there's a much slower response to PRP for joint OA. You'll see gradual improvement up to 3 to 4 months out. So usually we try one of these and then wait it out. You've tried to avoid cortisone, which may slow down the process. We have a lot of patients who, won't see that immediate relief like cortisone and rush for a cortisone injection 2 or 3 weeks. But that's the last thing you want to do. You kind of just need to wait it out. But once it's in there, it's in there. I think, the rounding out of the discussion is really on dosing, because so much of what we're learning over the past couple of years is that there really is a dose threshold you have to hit to see benefit. And so, there's a lot of different commercial systems out there that allow you to process PRP, and go over 50 of them. There's only a handful that are going to get you an orthopedic dose. And so you have to realize that PRP is used for wrinkles and hair restoration and a lot of other indications out there, wound care. And so some of these applications, the lower dose system's okay. But for orthopedics, you need 10 billion platelets. And how do you know that you have 10 billion platelets? Well, you have to go to a place that tests it. Otherwise, you're kind of just guessing. And so your platelets will fluctuate day to day. They'll fluctuate throughout the day. They bump up after you exercise. And so, depending on what your baseline platelets are, we may need to pull more blood, or if we were going to plan on treating 2 knees, we may only be able to treat 1 knee so we can get that baseline threshold where you're going to see some benefit. There's a threshold for tendons. There's a threshold for joints. And so the last thing you want to do is go spend all this money on a cash-based procedure and get a dose it's, we know just isn't going to work on you, period. And then the second piece of it is making sure it gets in the right place, so making sure they're using guidance, preferably ultrasound for soft tissue indications, because you can't see that on x-ray. So fluoro-guided soft tissue injections doesn't make a ton of sense in this space. So those are the things you want to ask, your provider about, how are they going to know the dose? What's their threshold? And then how are they going to make sure they get it where it's supposed to go?
Yeah. That makes sense. And I guess the last thing there is the data I've been presented with shows that there is a huge benefit to pairing this with Shockwave, and that you almost get a doubled coupling effect. Is that true? Or is that what you've seen?
There's not a ton of studies on Shockwave and PRP. So, you'll have people debate, do you do Shockwave beforehand? Do you do it afterwards as part of the recovery process? And I don't know if we know the answer. In our clinic, we use Shockwave a lot for in-season athletes. We try to grade every tendon injury. So, if it's a high-grade full-thickness tear, or a really got high-grade partial tear, PRP, Shockwave, it may not be strong enough. There's other things that we'll do in those situations. We use it sometimes afterwards because a lot of times people have muscular cramping or tightness as they're healing, or they're trying to activate those muscles around the injured tendon. So we get myofascial pain and trigger points, and we'll use Shockwave sometimes in those situations as well. But in a lot of cases, that's our first line for grade 1 or grade 2 tendon injury. And if that doesn't work, move on to PRP as part of our protocols.
Nice. And then I want to jump to stem cells next.
Yeah.
Are stem cells something you guys do?
Yeah.
Okay.
Yeah. So, but you have to be conscious of how this gets regulated from stem cells can mean a lot of different things.
Yeah. So that's what I've been, I went to another, I had a client bring me to his visit with the stem cell doc, and the way they were talking about it was very weird about how you can say it, how you can market it and list it and all this. And I was like, is this legal to do in Massachusetts yet? Or what's the deal with it?
Yeah. Yeah. It's, so to be able to market PRP or be able to market these stem cell procedures, you have to have a indication, FDA indication. And so depending on how you process these, they can get regulated similar to a drug or, a transplant, essentially, of your own cells. And there's no on-label indication for stem cells. So you can't, one, you can only market on-label indications. You can't market off-label indications for any medicine in the U.S., even though 60% of the medications prescribed are used for off-label indications. So we look at off-label as kind of a dirty thing, but the truth is we do it all the time. In fact, the majority of medications are off-label. So, you have to be careful in terms of how you market that towards patients. Two, being true to kind of where the literature is. And there's a lot less literature supporting autologous or allogeneic stem cells. So that references kind of the source of the stem cells than there is for PRP or some other biologic injections. In the US, it's legal to use stem cells that are within micronized fat and bone marrow concentrate. So those are the two sources that we can use legally as long as it's minimally manipulated. So we'll use commercial kits that are FDA approved for different indications. And then we use it for an off-label kind of application in orthopedics based on what studies are out there and some of that guidance. There's a lot written about placental tissue, so amniotic stem cells or birth tissue stem cells. You see these offered in other countries, but that's kind of been banned in our country for the past 3-4 years because of some really high profile negative outcomes and just lack of regulation. So the FDA really views those as a drug, which makes sense. It's coming from somebody else's body, it's dried or frozen, it's processed, and then put in a bottle, and then that's what's pulled up in clinic. So, it looks and smells like a drug, and the FDA regulates it that way. Mm-hmm. And none of those companies that are making those placental tissue products have gone through the FDA process. And so you want to be conscious of, those being out in the market because they're still being used, but they're really not regulated.
Mm-hmm. And so on the topic of stem cells, what conditions would you typically, or would someone want to use a stem cell therapy for?
Yeah, so a lot of the same ones as the PRP, and so, we can divide into soft tissue injuries, tendons or ligaments, and then joints. And so for joints, there's probably a little bit more data, the head-to-head studies where they've included PRP and the fat or bone marrow stem cell type products. They don't seem to help with pain or function that much better than PRP. What they offer is that they may offer a longer period of relief before the pain comes back. Now, that being said, there's certain patients where they just do better with the stem cell type products versus the PRP. But we don't really have a great sense of who's going to be a better candidate for one or the other. So it's usually kind of how we'll counsel our patients. The downside to the stem cells over PRP is it's a little more invasive to do a mini liposuction procedure or to do bone marrow aspiration to remove those cells versus just a blood draw for PRP. In addition, the supplies are a lot more expensive, so those procedures tend to be a higher out-of-pocket cost for patients.
So are you taking it from the patient themselves, or are these getting harvested somewhere elsewhere and then injected into this person?
No, so they're injected from you, so they're your own cells. So again, it's kind of like a transplant to some degree, where you're moving cells from one point to another. And so, they're regulated, at least the micronized fat as a cushioning cell, and broadly in orthopedics. There's some other nuances in terms of how this gets regulated. So you kind of stay within the box that the FDA has kind of used to make sure that these are safe. Mm-hmm. Procedures. For tendons, there are some studies looking at, head-to-head PRP versus bone marrow concentrate, and you do see better healing on MRI with the stem cell procedures. So the bone marrow concentrate at 6 months, you saw more patients heal their patellar tendon compared to the PRP group. Both groups saw improvements in pain and function, but maybe based on some of these studies, the stem cells may be stronger. If they're bigger tears, you have a high-grade partial tear, the PRP may not stay in that spot. There's different protein concentrates we can make off of your PRP that may hold it in place, but micronized fat is kind of a fatty globular structure. So if you inject that into these bigger defects, it's more likely to stay there and start that healing process. And so that's the nuance in terms of why we may recommend one versus the other in some of these situations.
Yeah. And then Prolotherapy is the other one.
Yeah.
That's kind of popular out there that not everyone knows about, but some people ask me about it too. And I honestly don't know a ton about Prolotherapy besides it's an irritating solution, I think, that you put into the tissue that creates a healing response. Yeah. So how does that differ from PRP, and why would you choose one versus the other there?
Yeah, so prolotherapy is kind of like the godfather of all this stuff. It's been around since the 1930s.
Okay.
And there are different solutions that you can use. The most common one that's used in the U.S. is dextrose, which is a sugar water solution. So you have these big sugar molecules that you inject into soft tissue injury, and it will start that inflammatory process. Your body doesn't want big sugar molecules sitting in the middle of your tendon, so it'll send in cells to remove those irritants, and in their wake, start a healing process. It tends not to hurt as much as the PRP, so these are things that we'll sometimes do in season for athletes, where they won't need to take a period of time off, to unload the tendon, because it's just a slightly gentler process. It's less inflammatory. The tendon's less vulnerable, in theory. Smaller tendons, they may not need as much of an inflammatory process, so joint capsule in the foot or ankle, or smaller ATFL, ankle sprain ligament injury, smaller tendons in the hand or the foot. I think these do well with. For arthritis, it also, there's studies, benefit for that. We probably don't know the mechanism as well in terms of how that turns off the inflammatory process. The downside of Prolo is that oftentimes you'll need multiple treatments. Mm-hmm. So because it's not as aggressive as a treatment, you may not get as much of a healing response. So usually patients will need somewhere between 4 and 6 treatments spaced 2 to 4 weeks apart, depending on what we're treating.
Where with the PRP, it's kind of a one and done thing, right?
Yeah, at the high enough dose, so there's some studies that show, if you do 3 injections of 5 billion in a knee, you can slow down the progression of arthritis, or you could do 1 shot of 10 billion. Mm-hmm. And so if these are an out-of-pocket expense, if you can pay for it once instead of 3 times,
mm-hmm.
At least in our clinic, that's kind of how we've structured what we use, which device we use, and how we space out these injections.
Yeah. And could you do like the thoracic spine, like the facet joints and things too?
Yeah, we don't, in our clinic, these are best done under fluoro guidance, mm-hmm. Just because they're deeper structures. They're more sensitive structures, the spine, some arteries, your lungs, in some of these areas. So, in the cervical, thoracic, lumbar spine, there are people doing facets, people doing it for chronic disc pain. Mm-hmm. And on some animal studies, you do see rehydration of a desiccated disc.
Okay.
So there's some sheep studies looking mm-hmm. at this. And there's some case reports showing that you can actually reverse disc disease in the lumbar spine. You want to make sure you're going to somebody who, again, understands dosing. And there's also a newer concept about treating the spine comprehensively that we use. Some of the regenerative medicine docs out there doing it mm-hmm. are using. So we get trained to do one structure at a time based on the insurance model. So the insurance will only pay for you to do a disc injection or a facet injection, or an SI joint injection, an epidural injection. So, these are the 4 most common injections you get in the spine, and you'll get them spaced out every month or 2 because insurance will only pay for one of those. Now, if you take it into your own hands and you take a regenerative approach, you're paying for this. So your doctor can treat all those structures, and all these things play off of each other. So you want to make sure somebody's doing a comprehensive approach to spine regenerative medicine.
Yeah.
And you may have to seek that out. There's not a lot of people locally doing that.
And so for me, I actually have ankylosing spondylitis to like a mild degree. I have like on radiographs, like I have no fusion or anything, but I'm very stiff. And so like my thoracic rotation is pretty limited. That's why I was asking, like, could you see like improvements in like the elasticity of like the facet joint and the capsules and everything from doing PRP injections?
It's an interesting question. I don't know. The inflammatory conditions, are slightly different.
Mm-hmm.
This, because it starts the inflammatory process, and kind of kicks that process up. People with rheumatoid arthritis, it's not that they're not candidates for this, but what we see in our clinic is instead of them being sore for 2 weeks, they may be sore for 4 weeks or 6 weeks.
Mm-hmm.
And so, I don't know if this would reverse that process or, stabilize those ligaments more. Or, I don't know. You may have to be a case reporter in and of yourself.
I'll be a guinea pig. I'll come in. I'll be a guinea pig. We can do a case report on the show. I'm all about experimentation here. And then, so that's actually another consideration though too, for people that do have osteoarthritis or a rheumatoid arthritis, is like a cortisone injection actually worse off? Or are they going to be worse from, the potential long-term side effects of that on the joint and the integrity of the structures around it?
Yeah, I think it's probably a dosing, issue.
Yeah, back to that.
The study that came out of BMC, where they showed that cortisone in a human may actually speed up the loss of cartilage. The way they designed the study is they had half the patients get saline, that's their placebo group, so just salt water injections, same stuff you would get through an IV, compared to people who get cortisone injections. And I don't know if it was every 3 months or every 4 months, but they were getting multiple injections a year for multiple years, and they did an MRI at the beginning and an MRI at the end. And the patients who had multiple cortisone injections lost 0.2 millimeters compared to 0.1. So a very small amount, but this is also only a 3 millimeter structure, right? So if over 2 years you're losing, just under 10%, that may be significant, even though it's, again,
mm-hmm.
We're talking sub-millimeter measurements.
Yeah.
The inflammatory process with arthritis, that's probably what causes that slow progression. So if we're turning it off, is there some benefit? Maybe the arthritic group was just more active. Maybe that's why they lost more cartilage and had nothing to do with medicine. I mean, there's still some unanswered questions, but if we can do something that slows down the progression of arthritis and doesn't seem to have the toxic effects with cartilage,
mm-hmm.
For some patients, that's important to them, and it may be worth the expensive PRP, even though the insurance companies aren't covering this.
Yeah, for sure. And then my last thing here I wanted to get through is what is the hydrodissection you guys do?
It depends what we're talking, right? So again, there's nuance to all this stuff, but a lot of times we're talking about it in context of nerves. So nerves can get entrapped with fibrous tissue, and so sometimes for ulnar neuropathy at the elbow, carpal tunnel, you'll try these injections, but instead of just putting an anti-inflammatory there, what we're doing is we're trying to put fluid around that nerve to possibly push away any fibrous tissue that may be tethering it. And so this is based on some animal studies where they put like a string next to the sciatic nerve in some rats, and they opened them up and they saw that just that irritation, that string next to the nerve, caused that nerve to swell. So nerves are very sensitive to compressive forces. And so, it's almost like taking, a power washer to your house and getting rid of the cobwebs that, may be tethered to these structures, allowing them to hide better.
Is this something that's going to like improve the neurodynamics of the nerve almost?
Yeah. So we do all these nerve flossing,
mm-hmm.
Techniques, in therapy, and, but if there's something tethered to that nerve, and there are natural tethers, these nerves don't want to be floating all over the body. So there are these natural tethers. And so when they do surgical release, they'll walk along the nerve and disrupt those fibrous bands, either with a finger or some other device. And so we're just trying to do that with fluid. Sometimes you can get scar tissue between tendons and fat pads, so in the knee or in the ankle, we'll use fluid to dissect and displace, so if you had Achilles tendon surgery, there's a ton of surgery, scar tissue after the surgery. Sometimes you can use a fluid to disrupt that. Frozen shoulders, we'll use hydrodilation procedures. So we'll put fluid in the shoulder and dilate the shoulder joint to disrupt any fibrous scar tissue in the joint capsule. And so, depending on what's going on with you, this may be something we're discussing as a treatment option.
And so with the nerve aspect, will you do this at like the nerve root and the foramen, or is this more of a peripheral thing?
We use it more peripherally because that's kind of what we see in our clinic. But even at the base level, an epidural steroid injection, some of what it's doing is putting volume around the nerve. And there's some studies looking at different volumes, and higher volumes, in some of these studies are shown to be more effective because you probably are displacing that nerve away from an irritant or maybe some early scar tissue that's developing around the nerve.
Yeah. Interesting. And typically on the nerve side, it's always some type of neurological findings. You have numbness, tingling, something like that.
Right.
Okay, cool. Interesting. And then I want to respect your time. I know you have to finish up here. Anything else you'd like to go over or tell people about?
Yeah. The only thing we really haven't talked about that we do a ton of are these ultrasound-guided mini surgical procedures. And so, all of these are, when I give a talk on this, I have a slide where we have like 15 or 20 different things that have been described over the past 20 years to try to get these tendons better. And one of the more effective things are these needling procedures. And so you guys do dry needling for a tendon, you poke it, you're trying to stimulate blood flow. The Mayo Clinic developed this device called 10X, and there's a couple other debridement devices that look like needles, but they're hooked up to vacuums and irrigation sources. So flush fluid in and suck fluid out. And so especially these tendons that have calcifications or higher grade scar tissue within them, putting a needle under there under ultrasound guidance, not cutting the healthy fibers, but flushing out and debriding the tendon, and then at the same time cutting the tendon out the diseased area to stimulate a healing response without damaging the healthy tendons is a really sleek way of approaching some of these issues, especially if you have a calcification or bone fragment in a tendon. This opens the door to a less invasive procedure where you may be in a boot for 2 weeks instead of 3 months. Or, if you have a calcification in your rotator cuff, you're back to activity on day one instead of, recovering from a rotator cuff repair over a 2-3 month process. And so it allows us to treat these tendons. And head-to-head, just with tendinopathy, it seems to perform about as well as PRP, but it's covered by insurance.
Is this the 10X?
Yeah, this is the 10X device.
Okay.
And there's a 10X bone, and so there's a lot of cool systems out there. And that same group at the Mayo Clinic developed something for carpal tunnel releases, which similarly is ultrasound-guided. They did a study with Dr. Eberlin out of MGH where they studied this compared to open surgery, and the outcomes were the same. People just got better faster. And in our clinic, 70% of patients are back to work after a carpal tunnel release, cutting the same structure within 3 days, the other 30% within a week. So again, cutting the recovery time in half or a third. So there's this growing body of ultrasound-guided surgical procedures that we're doing that are covered by insurance. So it may give you an option too, that besides these biologic injections, which aren't. And we can walk you through that stuff too.
And can you list some of those surgeries again you're doing or conditions you're treating with the 10X?
Yeah, so most of it's tenotomies. There's some bone removal procedures. So, we'll see some patients who have had a total knee and their arthritic pain's better, but there's a spur that's rubbing against the tendon. They're having ongoing pain. Or, you have a surgery and the tendon looks good. It's reattached, but there's a calcification or something else, that's rubbing or irritating the tendon. And so chronic tennis elbow, calcific rotator cuff tendinopathy, plantar fasciitis, gluteal tendonitis or bursitis, so most tendons around the body you can access with a 10X device, except for some of the smaller ones in the hand or foot. And so, not everybody can afford, the cost of a PRP or stem cell injection. But if insurance covers these procedures, these tenotomy procedures, that may give you another option out there besides some of these more expensive procedures.
And is this something you putting the patient to sleep? Or are they awake during this whole thing?
You're awake, and
painful?
we make an incision in the skin, because it's a blunt device, but you won't feel anything other than pressure during the procedure, and they're pretty quick. They're not. And the rehabs, you start that within 2 weeks.
Okay.
So in comparison to tennis elbow surgery, where you may be in a splint for 6 weeks or so, you're able to do normal stuff on day one. You just wouldn't lift heavy for, similar to the PRP for a few weeks until it starts to repair itself.
Yeah.
But it's on a surgery center, all done with local anesthesia. Usually there's not stitches.
Mm-hmm.
So.
And you guys are big too, like you mentioned, and actually a lot of your work, it seems like, is around the guided ultrasound thing. So for the patient's understanding, they can come right into you, and instead of having to come to you, talk to you, get sent out, like you can figure out on their like initial evaluation, you put them under, or in some instances probably, put them under the guided ultrasound and figure out, is this a soft tissue injury or not?
Okay.
Right?
Yeah, I mean, we saw a patient this morning who had knee pain. People debated where it was coming from. When we used ultrasound-guided, a tablespoon of numbing medicine into the knee, and his knee pain went away. And so all the other stuff that we showed up on his MRI that was outside the knee is irrelevant. It's on his MRI, but it's not the source of his pain. So we could spend time chasing our tail trying to work through all that. But we just kind of, in that situation, just proved where his pain's coming from. And now we can start talking about how we treat this instead of trying to guess what this is.
Mm-hmm.
And so ultrasound and these little diagnostic anesthetic injections that prove where the pain's coming from just gets us much further along in the process instead of kind of guessing.
So when you're using guided ultrasound as a diagnostic, how much do you use just guided ultrasound and you're like, oh, there's a tear right there or whatever, I can see, a bony overgrowth here, versus how often do you use the injections to do that? Because I'm thinking about getting a diagnostic ultrasound machine and going through the training for it. But again, I can't inject people with things. So
yeah, it may be 50-50. So, the ultrasound gives you a lot of information. I mean, you can even find that structure and push on it if it hurts. One of the most accurate tests for Achilles tendonitis is, if you squeeze the tendon and it hurts, that about outperforms anything else, in terms of how we figure this stuff out. And so, if you push on a tendon and it hurts, it's probably that tendon, and probably not referred from the joint or somewhere else. Before a procedure, especially something that's cash-based, we usually will use the numbing medications at that stage to really prove that we're putting it in the right place, to be respectful for the patient's time, and the rehab that follows, but also, the fact that they're devoting resources to this.
Mm-hmm.
So it may not work, that happens in some cases, but at least we know we're treating the right thing and we're not just guessing and blindly poking you with a needle. Yeah,
that's good. All right, man. Well, I know you have to wrap up here, so I appreciate your time. Where can people find you guys?
So we're Boston Sports and Biologics. We're about 10 miles outside of downtown Boston, right at the 9590 junction. Our website's BSB, so Boston Sports and Biologics, bsbortho.com. And we're happy to see anybody and answer any questions.
Yeah, I think your partner there, Eric.
Yeah.
I think me and him have been friends on Instagram for a while too, or he followed me or I followed him or something. So
he's great.
He does some pretty cool stuff on Instagram I've seen.
Yeah, he's doing a lot of those carpal tunnel releases, which is great. You can do bilateral and it's crazy. He's doing this thread release, and there's not even a code for that. Nobody can conceptualize that you can cut and release a carpal tunnel with string instead of with a knife. Yeah, so there's not even a code for some of the stuff we're doing. I mean, it's just light years ahead of, where we're headed. The analogy is in the 80s, we started doing all these camera-based surgeries, right? And before that, to open up somebody for an ACL was a mess. You'd spend, months and months and months recovering just from the surgery. Now with these ultrasound-guided, I think it's, another jump in terms of what we're going to be able to do from an orthopedic standpoint.
Yeah, absolutely. And, as a physical therapist, I just want to say I appreciate the stuff you guys are doing. That's, a little less invasive for people. It's more thought out. You guys sound like you make things more necessary. Like we see so many people that get these unnecessary injections, unnecessary surgeries, and just things that are, like repeated cortisone injections over and over and over again. It's like, this didn't work. Like, let's figure something out. So,
Yeah. It's simple, start with the diagnosis, make sure that, we're 100% right on. That's where the pain's coming from, and then build a treatment plan from there. And the last thing you want is a surgery and it's not where your pain's coming from. That's always a bummer.
Yep. I've had a couple of those happen. Well, not just a couple, more than that, but, I appreciate you guys being, advancing the field and being up to date with all the data of all the other options people have that they're just not presented with. So, and also for all of you listening, if you have any questions or anything that you want me to forward to these guys, we can gladly do that as well if you can't find them online. Anything else?
No, thank you. I appreciate it. This was great.
Of course. Thank you for coming on, and we appreciate your time.
All right. Have a good one.
84% of you that listen to this podcast frequently do not hit the follow button. If you've enjoyed any of these episodes, could you do us a favor and hit the follow button, leave a rating, and maybe leave us a review? It helps this channel more than you know, and the bigger the channel gets, the bigger the guests get. If you'd like to know more about training in person or online with Brett's Gym, Architect Fitness, please follow us on social at ARKITECT Fitness on Instagram or visit ARKITECTFitness.com. Or if you want to rehab with barbell therapy online or in person, check out @barbell.therapy or visit barbelltherapyandperformance.com. Thank you for taking the time to listen.